All right, Matthias.
And we're live in 5, 4, 3, 2, 1.
Good morning, everybody. Thank you for joining us again in Cerebrovascular Questions and Answers from Swedish and Seattle Science Foundation. My name is Matthias Costa. I'm one of the Cerebrovascular Fellows here. Leonardo Brasiliense, another one of the fellows, my colleague. Today we're pleased to have with us Dr. Santiago Ortega. Dr. Santiago Ortega earned his MD at the University of Alcalá in Madrid, Spain. Did internal medicine in neurology in the US, here in the Medical College of Wisconsin, and completed a neurocritical care and stroke fellowship at Columbia University, and an endovascular neurosurgery fellowship at Mount Sinai in New York. He's currently the director of neurointerventional surgery and neurology at the University of Iowa, and the neuroendovascular surgical neuroradiology fellowship director there. He's also the vice chair of the Mechanical Thrombectomy 2020 initiative and treasurer of the Society of Vascular and Interventional Neurology. He's the director of the Cerebrovascular and Neurointerventional Lab at the University of Iowa, and his research interests include cerebral autoregulation and hemodynamics, neuroimaging as a selection tool, and developing novel endovascular approaches and devices to treat cerebrovascular ischemic and hemorrhagic diseases. He has over 170 publications in prestigious journals, as well as industry and several investigator-initiated studies, including an NIH R01 funding. Dr. Ortega, thank you so much for joining us. We appreciate it, and you can share your screen.
Thank you so much for such a kind introduction. If I knew you were going to read it all, I would have short it out a little bit, but it's really a privilege. Thank you for the Seattle Foundation for this opportunity. Dr. McDougall, always a reference for all of us. And today, over the next 45 minutes, the idea would be to talk a little bit about a topic that is close to my heart, and my team and I have dedicated probably the last 2 years on research, which is the cervical tandem occlusions. These are my disclosures, and basically the idea over the next 40 minutes is review a little bit of the current status, the evidence that the guidelines tell us about cervical tandem lesions. I'm going to present you the most recent literature on safety and efficacy for endovascular approach for tandem lesions. And then the last few slides is what is coming up over the next few years. We all here know that we have actually witnessed ourselves a scientific revolution in ischemic disease over the last decade. And we know that endovascular therapy is a very potent and efficacious treatment for a large vessel occlusion in the anterior circulation, and for the last 2 months we have evidence, class 1 evidence for posterior circulation in the early and late window. However, during these pivotal trials, they had very stringent inclusion criteria, and therefore different cohorts or different populations were not kind of included in these trials. We're going to hear very soon information about the 2 now recently finished clinical trials in large core. We're starting to see coming up MIVOS and DIVO trials and low NIH stroke scale. When one of the also left alone or not included population in these important trials was the cervical tandem lesions, which actually represents up to 15 to 30% of the acute LVOs that we currently treat. But what is a tandem lesion? Well, we define a tandem lesion as a high-grade stenosis or occlusion of the cervical segment of the internal carotid artery with a concomitant intracranial LVO. We know from all natural history trials that if these lesions are left alone, you don't treat the intracranial or nor the cervical, the prognosis is pretty much dismal. Unfortunately, as I mentioned, the number of tandem lesions included in the Hermes meta-analysis and Aurora meta-analysis was very, very small. We had less than 10% of the patients. However, in the subgroup analysis from this patient-level meta-analysis, as you can see on the bottom, we found that definitely treating the LVO, the acute lesion in this patient population, is beneficial, and it has an effect similar to the LVOs that did not have a tandem lesion as a cause of the LVO. Because this is the best level 1 or the best prospective randomized evidence we have, just a mere subgroup analysis. The current guideline says that it might be reasonable to treat with mechanical thrombectomy tandem occlusions within the first 8 hours with a class and evidence 2B BR. However, during these trials, there was very little information about how to select these patients. How can we treat the extracranial lesion? Should we do the extracranial first, or should we do the intracranial first? What is the order of reperfusion? In addition, we know very little of which technique for the cervical segment is actually a better option. Is it angioplasty, and then we'll deal with the lesion later on with CEA or stenting, or is acute stenting the best approach? In addition, we have very little data or very little information from these trials about what is the best antiplatelet regime when you use a stent. And a lot of people really have hesitance to give IV TPA in patients who present with tandem lesions, just in case a stent might be needed later on, and they are concerned about the mixing of IV thrombolysis with antiplatelets. And again, if we use a stent, should we use dual oral antiplatelets? Should we do IV antiplatelets? Should we do single antiplatelets as our European colleagues do in multiple occasions? Then let's start a little bit about what we have in terms of expert opinion. Two main surveys. The first one from our colleagues from Canada, with some participation of some US experts, about 160 stroke and endovascular experts from different backgrounds, really kind of try to, were surveyed and really try to respond what was the best approach in their expert opinion. 59% considered acute stenting in the context of a tandem, cervical tandem lesion should be done, whereas 41% would never use it in the acute setting. And the reason for not using it was the fear of high risk of intracranial hemorrhage, as well as a little bit of fear for acute stent thrombosis. When they ask other questions about the technique, 33% would say that they would never use a stent if IV TPA was given. And when they ask about what is the best approach, do you take care of the lesion first, or you take care of the cervical lesion first, or the intracranial lesion first? About 65% prefer to go for the brain first and then deal with the neck afterwards. The antiplatelet regime preferred for these experts was dual oral antiplatelet in the acute setting. We took it a little bit beyond and did an international survey with over 220 cerebrovascular experts in the different regions, big representation of North America, Latin America, and Asia, a little bit less of Europe, Africa, and Australia. And these experts had a very diverse background. All the subspecialties were represented, including neurosurgery, neuroradiology, neurology, as well as stroke experts. And about 3% had include other specialties such as neurocritical care. The majority of surveyed people were primarily had an experience of over 6 years of practice, were in academic medical centers, primarily in comprehensive stroke centers. And when we asked them first about the technique, as you can see here, there was so much discrepancy about what the best approach is, even among experts. 41% thought that we have to do angioplasty and stent it in the acute setting, where, and in contrast, 38% thought angioplasty or angioplasty with aspiration is the way to go. And again, a lot of discrepancy about what is the first best approach. Anterograde, going first to the neck and fix then the brain, versus retrograde, going for the brain first and taking care of the neck afterwards. When they were asked about the timing of this cervical lesion, obviously the ones that had responded that they wanted an acute stenting in the acute setting went for that. However, the majority of the ones who decided angioplasty is the way to go decided that you need to deal with that lesion before the patient goes home. And then when we asked about why not use a stenting in the acute setting, again, the fear of intracranial hemorrhage or hemorrhagic conversion was the main reason not to do acute stenting during mechanical thrombectomy. And when we ask about antiplatelets, the heterogeneity on responses was even more dramatic. I think we have no clear idea of how to do this. 33% thought, let's give dual antiplatelets. 29% thought, let's give 2B3 inhibitors in the acute phase. And even now with the new medication as IV cangrelor, about 5% were using that at that time. And some of them even use the combination. Let's start IV antiplatelets and then PO antiplatelets in the same setting. Therefore, as you can see, there is not even consensus among our experts. But do we have any other evidence to support the treatment or any kind of technique to approach acute tandem lesions other than just expert opinion? Where I'm going to kind of review what I think is the most recent as well as the most robust evidence. And the first question is, what is the best approach? A stenting versus angioplasty? What kind of evidence we have to kind of deal with these patients? Probably the most, the first of all the registries that we have available is the data from the STRATUS registry. As you all know, STRATUS is a single-arm prospective thrombectomy, mechanical thrombectomy registry with about 1,000 patients that were treated with Solitaire. And in that population, about 147 patients were tandem lesions. From those, 80 patients were receiving acute stenting at the same time as they received mechanical thrombectomy, whereas 67 received angioplasty or other treatments such as no treatment or aspiration. When they looked into those three groups, this study showed for the first time that patients who had received acute stenting with mechanical thrombectomy had higher rates of functional independence at 3 months, measured by MRS 0 to 2, after adjusting for confounders, without an increase in the rate of symptomatic ICH. More importantly, in the same study, an adjusted multivariable analysis actually identified stenting as an independent predictor of good outcome in conjunction with NIH at baseline and aspects in patients with tandem lesions. It was afterwards the TITAN registry, which is a registry primarily from European centers with some participation of US centers, that put together this, I think, in my opinion, landmark study that really kind of made us think about the different approaches to tandem lesions. In this initial registry, they collected 482 patients, and they divided the strategies in four. For the patients with acute tandem lesions that were treated with carotid stenting and antithrombotic in the acute phase. Carotid stenting without antithrombotic, they basically gave a little bit of heparin, waited for a CT scan, and then gave antiplatelets afterwards. Did balloon angioplasty in the acute phase, or did thrombectomy alone? And we can see here some signals. Actually, in the multivariable analysis, after adjusting for confounders, there was increased rates of successful reperfusion in patients who received carotid stenting in the acute phase plus dual antiplatelets, comparing with the other groups. Also, there was a trend, although in this study was not significant, about favorable outcomes. And the most important thing is all this fear about hemorrhage was not really identified in this study. The group of patients who had dual antiplatelets had actually similar rates of symptomatic ICH comparing with the other two groups. Subsequently, the same group combined forces with the French registry called ETIS to increase the sample size, and they kind of repeated the study with a little bit more advanced statistical methodology. And here, with 150 patients more than the previous study, they actually now found that there was a significant difference in the dichotomized outcome as well as in the ordinal shift analysis for patients who receive acute stenting of the cervical lesion when compared with patients who did not receive acute stenting. Furthermore, that benefit for favorable outcome was out without a penalty of an increased rate of symptomatic ICH. Although there was a little trend, it was not statistically significant. And the mortality rates were similar among both groups. The rates of successful reperfusion, which is something important, was also higher in the patients who received acute stenting. And I invite the audience to think about why. Was it because of the stenting itself, or was it because of the dual antiplatelets? We'll see more data afterwards about this. And when they did an analysis about a pre-specified analysis of subgroups, they saw that this favor stenting effect was kind of very similar throughout all the subgroups, regardless of age, if they receive IVTPA, aspect, and NIH stroke scale. And definitely the interaction was, and the effect was higher in patients with atherosclerosis, it makes sense comparing with dissection. We last year presented at the SVIN the kind of competing registry, if you wish, from our group, the US Tandem registry, in which we collected 623 tandem lesions from 16 different sites, 15 from the US, 1 from Europe. And the patients received stenting in the 363 cases versus non-stenting in 260. And the non-stenting included angioplasty aspiration, or just cross with the guiding catheter, balloon guiding catheter, if possible. And we actually show the same kind of effects. There was a significant difference in a 3 months outcome in patients who received acute stenting versus not acute stenting, with almost like a effect size or delta of almost 15 to 18%. And this was significant in the dichotomized outcome as well as ordinal outcome before and after adjusting for confounders. Similar to what they found, we saw that there was not an increased rate of symptomatic ICH among these two, between those two groups, and the rate of successful reperfusion remained higher, significantly higher in the patients who underwent acute stenting. When we also did the subgroup analysis, this effect of stenting was consistent in all the subgroups, including age, IV thrombolysis, the etiology, aspect, antiplatelet use, technique use, as well as if there was a complete occlusion versus stenosis. And more importantly, our trial, as you will see later, our study, as we saw later, we'll see later, did include patients in the late window, whereas Titan only included patients within the first 8 hours. And for the safety group analysis with ICH or PH2 as a primary outcome, we did not see any kind of significant differences between groups, subgroup analysis favoring one versus the other. Then basically there was no really kind of increased rates independent on the group you were at. We also tested this hypothesis in a national inpatient readmission database. And here, as you guys know, we don't have MRS per se, but we have good data about complications. And what we studied is we collected all the patients from 2017 that underwent acute stenting in the context of mechanical thrombectomy versus just angioplasty and mechanical thrombectomy. That year in this database, about 1,400 patients received acute stenting versus 651 angioplasty. And when we looked into the risk of hemorrhagic conversion of death as a composite outcome, we did not see any differences among groups, significant differences among any of the groups. Not pertinent to this talk, but I had also a little bit of an interest in looking for the patients who did not underwent acute stenting, what happened with them? What was the reperfusion technique used? And it's interesting to see that the patients who actually received CEA, the majority of the CEA was performed after a week. And you can maybe infer that a lot of them got the CEA after they left the hospital. However, the patients who underwent a stent, the stent occurred within the first 7 days of hospitalization. When we look into a little bit more robust data, this is a meta-analysis from our European colleagues published last 2 years ago in JNIS, and they actually asked the same question. They included 14 different studies that compare these two groups, stenting versus not stenting for acute cervical lesions, and they found also a significant difference in favor of acute stenting for decreased disability at 3 months in this population, without having a significant increase in the rates of ICH nor mortality. Although in this study, there is definitely a trend but it was not statistically significant. And the number of patients included in this meta-analysis is about 1,200 patients. We repeated the same with a little bit more strict criteria for the studies included in the meta-analysis a year later, and we found the same effect. Definitely, stenting had better, higher rates of and odds of this decreased disability at 3 months compared with the other groups. We also found that stenting, as we saw in the registries, had a higher rates of successful reperfusion, defined as modified TICI 2B or higher, without having an increased rates of symptomatic ICH or mortality. Okay, then that's kind of the most updated literature to answer the question of stenting versus not. We don't have level 1 evidence, we don't have randomized data. But what is the technique? Do we have any data that cannot really help us out to determine what technique is better? Anterograde, which means fixing the neck as we go up with a definitive treatment like a stent, or retrograde, we go for the brain first and then we deal with the neck afterwards, but we first take care of the LVO. Well, this is a very interesting question that we don't have a clear answer. The first on trying to answer this question was, again, the Titan colleagues, in which they actually identified 289 patients with atherosclerotic lesions, and they divided the population in the ones that got the head first, LVO first, versus the neck first. The problem is, as you can see, is the heterogeneity of techniques used for dealing with the neck in those two groups was substantially different. A lot of people in the neck first got a stenting, obviously, versus head first. Only less than half of them had a stenting. But what they found when they compared these heterogeneous groups was that the only significant difference after adjusting for confounders among groups was the timing. When you fix the neck first, it takes approximately 15 minutes more to kind of have a reperfusion in the of the LVO as you spend some time fixing the neck. But there were no other differences in terms of TICI, ICH rates, or MRS at 3 months. This meta-analysis tried to kind of answer that question. And similarly, when they compared the intracranial first versus extracranial first, there were no significant differences among functional outcomes, reperfusion rates, and symptomatic ICH in this population. We we try to answer the same question in our meta-analysis. It's important to recognize that the number of studies that really identify or characterize the technique is very low. We could only include 4, but we saw that perhaps there was a trend or a significant difference in those 4 studies, including approximately 250 patients total, towards the retrograde benefit. Retrograde was associated with better functional outcomes and better reperfusion rates in this population without an increased rate of symptomatic intracranial hemorrhage or mortality. Again, this has to be taken, analyzed or considered very carefully because the number of studies in this meta-analysis was very low. And something that I invite the audience also to think about, for those of you who do this in clinical practice, is, are all the stenosis or all the lesions the same? This study, this subgroup analysis from the Titan group made me think a lot, because this is what I see also in my practice. They actually divided or subdivided the lesions between stenosis, which it would be 90% or more, versus occlusions or near occlusions. And as you know, when we are dealing with a cervical occlusion, we do not see what is beyond the lesion. We don't know the burden of clot we have in the cervical. And but when I do these cases, I have a very hard time to get a TICI3 because I frequently have some distal emboli or even emboli in other vascular territories such as the ACA territory. And I think it's because the burden of clot that we have in these patients in the distal cervical lesion is much higher than when we are dealing with an stenosis and we see anterograde flow and only an LVO distally. And in this study, they found that for them, it was the same. It was extremely difficult for them, or the rates of TICI3 was much lower in the patients who had a complete occlusion when compared with the stenosis. And again, is this something that is a different kind of degree of disease? Do we need to utilize different technique in these situations, such as balloon guide and flow arrest more frequently? This is something that obviously we don't have an answer, but definitely this is a fact, and we see the same kind of phenomenon in our registry. Another important question that a lot of people have a stigma and they don't use is, should we use or should we put a stent if a patient comes within the early window and have received the TPA by our colleagues, vascular neurologists? And again, a lot of people, as you saw on the survey, did not do that because they were all concerned about the increased risk of asymptomatic or asymptomatic PH1, PH2. But when this question was asked in the Titan registry, they did not find any significant difference in the rates of symptomatic ICH nor parenchyma hematoma type 1 or type 2 in that population. What they found actually, which is interesting, is the patients who received IVTPA had lower rates of mortality when compared with the patients who did not receive IVTPA. And when they look at the successful reperfusion rates, they found that prior use of IVTPA was associated with higher rates of successful reperfusion. And I'm not surprised, even though this study was done 2-3 years ago. Remember our latest data from the CHOICE trial. It looks like that they might IVTPA, perhaps intraarterially in that CHOICE trial, was helpful to kind of help to recanalize better the patients, or perhaps dealing with the microcirculation thrombosis that is now a very hot topic in our field. But again, IVTPA doesn't seem to be associated with higher rates. We did ask the same question in our meta-analysis, and we did not find any significant increase of symptomatic ICH in the population who received IVTPA compared with the ones that did not. And we asked the same question to our registry, our US Tandem registry. We had a total of 375 patients who received only mechanical thrombectomy in the 283 who received mechanical thrombectomy and IVTPA. The majority obviously were presenting in the early window, and whereas we didn't find a complete a difference in functional outcome when we compared the entire population. When we did a sensitivity analysis only with the patients with tandem lesions presented with the within the first 8 hours, we really found that patients who received IVTPA had a significant improvement in the disability rates at 3 months when compared with patients who only received mechanical thrombectomy. Again, the sample size is not that large, but there was a clear benefit in terms of significance. And more importantly, when we looked into the rates of symptomatic ICH, PH2, or even petechial hemorrhage, there was not increase on those groups, even after adjusting for confounders, which included age, NIH, and aspects. Therefore, that might not be that myth might not be as real as people think. However, again, we don't have a level 1 randomized data to support that. What we found in our registry is actually that perhaps the combination with a specific anti-platelet regimes and IVTPA might be a little bit worse. In fact, we had a P interaction here, and when we look into these two groups, it seems that the combination of IV antiplatelets in the context of IV thrombolysis might increase the rates of symptomatic ICH. And that's something that we are exploring now and trying to understand better if it's a specific IV antiplatelets, 2B3 inhibitors versus cangrelol versus regardless of which one it is. And then just over the last next 10 minutes, just to kind of finalize the evidence, we're going to talk a little bit about what we know about antiplatelet regimes. Initial literature was very concerning about the use of 2B3 inhibitors in the acute phase of tandem lesions because there was an increased rate of symptomatic ICH. But again, these are small cohorts of 20-30 patients. Same here, 24 patients consecutively treated with tandem lesions, 16% hemorrhagic in symptomatic intracranial hemorrhage, very high rates. But when these things were looked into a higher cohorts with the Titan group, they did not find any significant difference about from the different regimes that were used in the patients, integrally for 24 hours, aspirin plus clopidogrel acutely, aggrastat plus dual antiplatelets, and aspirin plus IV, which is a very common practice in Europe, since they have the ability to have IV aspirin in their labs. Also, when we looked in our data, we did not see any significant differences in terms of MRS at 3 months between the 3 different regimes, and nor any significant difference in terms of increased intracranial hemorrhage, petechial hemorrhage, or symptomatic ICH. But what we found, and this is what I mentioned in my initial slides, is that the patients who actually received dual oral antiplatelets or IV antiplatelets, which the majority, of course, were patients who received acute stenting, had higher rates of TK2C and 3, like excellent reperfusion, compared with the ones that had only a single antiplatelets or no antiplatelets. Therefore, there might be a benefit underlying the fact that when we put a stent, we do dual antiplatelets, and perhaps we improve our chances of getting successful reperfusion because of the combination of both agents, the stent as well as the antiplatelets. And then this is something fresh from the press, as we used to say. This is just presented last week in our national SVIM meeting. It was also a late-breaking abstract, and we presented the data from our registry about the late window. There is no, to our knowledge, there is no much data on terms of the benefit of doing acute stenting in tandem occlusions or tandem lesions presented in the late window. And in our registry, as I mentioned, we have a total of 268 patients that presented in the late window. And when we compare these two patients, we evaluated obviously the differences among the groups, and even though there was some differences in NIH aspect and of course TPA, early window had much higher rates of TPA than late window. We adjusted for all these variables when we assessed our primary safety and efficacy outcomes, and what we found is basically no difference. The effect of treatment of these lesions is from the endovascular standpoint is similar whether we do early window or late window. Very similar rates of independence at 3 months during the late window, 6 to 24 hours compared with 0 to 6 hours. And this is actually the probability of good outcome. As you can see, it's almost a straight line. It doesn't matter when you treat these patients. If you treat these patients endovascular, you take care of the LVO, and then you deal with the cervical lesion, you're going to have good outcome. Then those patients must be treated even if they come after 8 hours. It sounds weird to say this, but there are places, because we don't have any evidence on late window, that might not offer endovascular treatment of the LVO in late window patients arriving with tandem lesions. And then when we looked into the differences in the rates of intracranial hemorrhage, PH2 or petechial hemorrhage, and compare early versus late window, as you can see here, even after adjusting for the confounders that I mentioned, the aspect, the NIH, the time difference of treatment, the rates were not significantly different, were very, very similar. Then in conclusion, I think we can say that probably acute carotid stenting in the context of acute tandem lesions might be safe and effective. Obviously, the data that we have is allocation of retrospective data with no randomization. Also, acute stenting seems to be associated with higher odds of successful reperfusion and good functional outcomes when compared with no stenting or angioplasty. The IV TPA, based on the data that we have available, might be safe in patients presented with the early window, and probably we should not deprive that therapy to this patient population, although again, we lack on randomized level 1 evidence. There is insufficient data about what antithrombotic therapy might be best, but definitely the use of IV or dual antiplatelets when we put a stent might have something to do with increased rates of successful reperfusion. And finally, the treatment of tandem lesions in the acute, in the late window seems to have a very similar effect when compared with the early window. But what we really need is randomized controlled trials to really compare both techniques and also kind of have a better, more structured antiplatelet regime to really evaluate safety. And that is something that everybody agrees upon. These are the results of our survey, and 70% of the cerebrovascular experts will be willing to randomize in a trial because they think there is equipoise. And for that, there are two ongoing trials that will give us some answers. One is in Titan in Europe, primarily. In France, they are comparing, it's a superiority trial in which they are comparing mechanical thrombectomy with acute stenting versus mechanical thrombectomy with alone or with some angioplasty. And the primary outcome is MRS at 3 months. And our colleagues from Canada are also doing another trial, which they are comparing again the same techniques. In this case, the outcome is a reperfusion plus delta NIH outcome at discharge. Then hopefully we have some data, and I think we really need our trial in the US, and hopefully it will be coming. And obviously, this is work not just for me, but for my wonderful lab and my team. I couldn't do that without them, and for that, I really appreciate all the support and all the long hours that we have invested in trying to answer these important questions. Thank you for your time, and I'll be happy to take any questions.
Thank you very much, Dr. Ortega. It was an amazing talk, really informative, and many points and questions from everybody here. And my colleague Leonardo, Dr. Montiel would like to start, apparently.
Thanks again. That was a wonderful talk. I guess these are very difficult lesions, and I kind of jump between the acutely stenting and non-acutely stenting group. And for me, the biggest determination is the volume of infarct prior to beginning the procedure. Does that influence your decision now that you have done this very in-depth analysis, not just the aspects, but the volume? Because I think sometimes the aspects is not an accurate representation of the risk of intracerebral hemorrhage due to volume of infarct. Thanks.
Thank you so much for your question, Dr. Monte. It does tremendously. We are now analyzing in our cohort, because we have such a large cohort of a late window, we have some CTP data, and we have aspects in all the patients. Then definitely we are looking into that, answer that question. What I do currently in my practice is when we have, and by the way, those two trials that I mentioned are going to only enroll patients with aspects 6 or more. They are not going to include large core. Then at this moment, what I do is if I see that the aspect is low, like a 6-ish, 5-ish, and we decide to go ahead and treat, then definitely I do, in those patients, I don't put a stent. Those are the only population at this moment until we start to participate in a clinical trial that I would use balloon angioplasty. I will just take care of the intracranial lesion, and I will repeat the CT scan and look at the lesion later on and decide to treat based on how the patient looks like. But I completely agree with you. Large core still, I think we're going to see some data coming up probably in the ISC this year. The two trials, as you know, Tesla and Select2 have been completed about 3 weeks ago, and in Select2 we were able to include some tandems. Then my hope is we can do a subgroup analysis on those to really see what the effect is. But at this moment, if it's a large core or close to 6, I tend to only do an angioplasty and not do acute stenting in the acute phase.
Great, thank you.
Great. You?
Dr. Ortega, fantastic talk. Really appreciate all the in-depth knowledge that you shared with us. My question is, does distal embolic protection device, does it play a role on this? Because I would imagine that across the board, most people would use it. But I would imagine that in the acute setting, there are probably instances where people don't use it. So does that information play a role on this?
It's an excellent question too. The answer is, first of all, outside science, if you don't document distal protection device or flow arrest, you don't get paid for the stenting, but that's not important. For the science itself, I think I think is if you have an stenosis, not an occlusion, an stenosis, and you deal, whether you do anterograde or retrograde, but if you do let's say, go for the brain first, do angioplasty, go for the brain first, and then you want to put a stent afterwards. I think in those instances, it's important to put a protection device because you have opened already the flow intracranially and you want to avoid any distal emboli in those cases. Then I do that. However, in the cases in which I go with a balloon guide and I have a complete occlusion, in those instances, probably what we do or what I do is I do flow arrest, do angioplasty, and then I don't open the balloon guide immediately because as I said, those patients sometimes have a lot of clot burden distal to the occlusion since there is not anterograde flow. Then in those instances, probably the use of a protection device is not as important. What you need to do is probably clean up the cervical segment. And in some instances, especially when the lesion is very calcified, you might need to put a stent early on, even before you go to the brain. Then I think when we do take care of the brain, and then we go back and we decide to fix the neck, I do put a protection device. When I'm dealing with a complete occlusions with high burden of potential clotting, I tend to use a balloon guide catheter, do flow arrest, do angioplasty under flow arrest, and even try to put my aspiration catheter all the way up to the cavernous segment, aspirating as much as possible to try to minimize. Evidence for that, zero. This is just based on my experience. But what I've been trying to kind of deal with chronic, we have a lot of carotid occlusions in Iowa because it's all Caucasian population. Approximately 30% of our strokes are carotid occlusions. And I have a very hard time if I don't use a balloon guided just to kind of really not have distal emboli. Then in those instances, sometimes I put the stent, clean the neck and put the stent to improve the flow before I go for the intracranial lesions in order to kind of maximize flow and then hopefully also decrease the reocclusion rates on the intracranial segment. It is case by case. I don't have a protocolized answer for you. I would say elective or after the LVO, if you have you decide to put a stent, yes, please put it. If you are dealing with occlusion and you need to have a lot of clot burden, just flow arrest itself might be as good.
Dr. Ortega, you show your the US Tandem occlusion registry with you showed essentially no differences between early and late windows. How late was the late window?
That's excellent. Up to 24. We did exactly the same criteria as we had in the Dawn trial, and we did 0 to 6, 6 to 24. We have a cohort of patients we treated beyond 24, and that we are analyzing just for the extreme late window. But these specific data are only 0 to 6 versus 6 to 24.
Okay. You showed data about the IVTPA.
Correct.
What do you think that is like the effect was better in tandem occlusions versus non-tandem occlusions?
Yeah, the effect when you compare the whole cohort, including a lot of patients in the late window, there is a little bit of disproportion, right? Because there is a lot of people who are not going to get TPA in the late window, and in the early window, some had, some didn't have. However, when we did a sensitivity analysis on only patients within 8 hours, and compared the patients who did not get TPA and patients who got TPA, there was a significant difference. Again, very small sample size, 120 versus 58. But there was a significant difference towards benefit from people with IVTPA. And as you know, now there is a big field of supporters or line of research about this, because recently our colleagues from Barcelona published the CHOICE trial. And the CHOICE trial was basically a trial in which they actually give intraarterial TPA after reperfusion and compare with no intraarterial TPA, and they found that there was significant benefits. It was a single cohort, but it was 100-something patients. Benefit of intraarterial TPA compared with nothing after the reperfusion. And there is now a lot of people who are doing some small sample studies about giving IVTPA during thrombectomy. You just don't even do it before. You are in the angio suite. You are opening the vessel because what the belief is that it might help, as we saw in our data, to kind of really achieve better, excellent reperfusions, as well as perhaps this reflow phenomenon that we are now kind of studying more in depth, about, you can open the vessel, but sometimes why 50% of our patients who get complete reperfusion, or 30%, because some of them is because they have large core, but some of the patients with aspect 6 to 10, when you open the vessel, you still don't get a great outcome. There is definitely comorbidities such as age and other factors that might influence the outcome. There is some subgroups that perhaps we have this microcirculation or other factors that we don't reperfuse and we don't see it in the angiosuite that might benefit from this. And I think that's why in the patients who receive intraarterial, intravenous TPA, or even in our antiplatelet cohort with intravenous TPA, intravenous antiplatelets, had better TK2Cs and 3s, because there is an effect of this antiplatelet medication that might improve small vessels that we don't see in the angiosuite.
Okay. Do you have what is your approach to dissection versus plaques?
That is a very excellent question. To be completely honest with you, I don't have an answer. I think for plaques, we basically follow what I mentioned, stenting whenever there is no large core or a big infarct in the CT perfusion or as a CT. For dissection, it's a little bit more tricky, right? Because sometimes you have a dissection, which you don't know the extension of the dissection, you go with the guiding catheter or intermediate, you touch the flap and opens up. But sometimes it doesn't happen. And in those instances, you have to stent. But stenting, we don't have a great stent for dissections, especially when there is a dolichostatic or curved vessel. When it's straight, it's easy, but most of the time they don't have that. They have like a very a curvy abnormal vessel, and then the intracanal stents, we don't have sometimes the size, they don't open well. Then lately, sometimes we've been using some of the flow diverters with higher radial force, with no data, obviously, but when you need it, they might adapt better to the tortuosity on this dolichostatic vessel with the dissection when you need it. But sometimes you don't need it. Sometimes you can go straight with the intermediate, touch the flap, and in those instances, I just keep them on antiplatelets or heparin afterwards, and then I just observe. In the ones that you don't open and you have a very severe stenosis or clot formation, I tend to put now probably flow diverters. And when I choose one, I tend to use, I used to use the Streamline because I had a little bit more radial force, but as you know, the system is not as good. And lately I've been using a little bit more the Volve because it has a little bit more radial force.
Okay, and you showed no significant difference in between dual antiplatelets and not dual antiplatelets in symptomatic ICH.
Right.
But do you think there is any role for cangrelor in this setting that you can?
This is an excellent question. We only have 19 patients in our cohort with cangrelor. Then we are kind of doing right now. We are analyzing the data but with such a small sample, the only thing we can do is a propensity match score. With similar aspect, age, the data will not be very robust. But we only have 19 patients using half of the dose of the cardiologist. And I'm very interested on this because we saw that patients with IV, with 2B3 inhibitors, which is the majority of the population we have in our registry, might have a little bit more hemorrhage when you combine with IV TPA and have a little bit higher non-significant rates of hemorrhage. But perhaps cangrelor might be safer. And that's something that might be very interesting, and also because of the half-life. Then we are working on analyzing the data and hopefully working with a couple of other groups that are doing more cangrelor. I don't know if you guys use cangrelor in the acute phase, but that's something that potentially might be a very especially for, as Dr. Monteith was saying, like if you have a large core at the end, or you have concerns of hemorrhagic conversion and you need to do hemicrania, or the volume is too much and you need to do hemicrania afterwards, you can definitely stop it and then go for it without the need to wait for several hours or days if you do dual antiplatelets.
Okay. Thank you very much, Dr. Ortega. Those were my questions. There is a text, there is somebody from the chat, Dr. Mohammed asking for if you have some kind of link to download the tables in your presentation, if you were allowed to share.
Download what?
They want your presentation with the tables and the summaries and
Sure. What I can do is, if they want to email me, I'll be happy to share some. Some of the data are probably not completely shareable, but I can share everything that we haven't published, that we have published already. Then that would be, I can put, this is my email. I don't know if they can see it. Not trying to promote myself, I promise, but since they asked, I'm happy to share. Then this is my email. Just feel free to email me, and I'll be happy to share. Me or any Juan or anyone from my group can share some of the data that we have already published.
Okay, thank you so much. It was really a nice lecture, great questions, and any final remarks?
Yeah, I'd like to jump in and just say that I really loved the talk, and I learned lots. And what I really love when someone, sinks their teeth into real practical problems, things we see every day in the lab. You really addressed a lot of questions that we have when we're actually doing cases, and it's really, really lovely to see your work. I want to return just quickly to the clot burden issue, though, because I think that's a real issue and very hard to determine how much clot there is and what to do in that setting. And we've seen in times before with acute carotid occlusions without tandem lesions, a lot of people would have emergent endarterectomies, and you'd back bleed the carotid, and you'd see huge amounts of clot come out. And so that's always tempered my approach. And what you brought up at the end that wasn't really included in the talk or accounted for in the data, I think, and is incredibly important, is the use of the balloon guide and the proximal control, and sort of figuring out that issue of clot burden. And I know I've certainly had cases where you really could see the filling defects and didn't think you could vacuum out all of that clot burden. And in some of those cases, if there was reasonable, ACOM or whatever, open the intracranial occlusion and actually leave the carotid closed, just because I didn't think I could clean out the carotid. So I think those sorts of intra-procedural decisions, there's always going to be one-off and nuances that are really hard to study. But I think it was really great that you brought up that sort of how to handle that at the end, because I think that's really a confounding issue for us.
Thank you. Yeah. I think when we have a complete occlusion, it's a different animal. It's a different animal. We don't see what we are seeing. We don't see what is beyond the plaque. And sometimes, as you know, you just do angioplasty and everything looks great. The microcatheter is bouncing afterwards, and then you can do a little microcatheter injection, and it's great. But sometimes you have so much burden of clot, you do make the mistake to do a strong injection, and you throw out a shower emboli. And definitely, completely agree. And I think as the Titan group showed, I think the outcomes in complete occlusion versus stenosis is different. It's a higher risk category, higher risk stratification category for tandems.
And probably worse still for the dissections. I think they're more thrombogenic. The clot burden tends to be even higher in those cases. So there's something you really have to be cautious about. And then the last thing I wanted to just touch on is the intravenous TPA, or the intraarterial TPA. Really interesting. There's a pretty long experience for some of us who used initially prourokinase in the original trial, right? And then for years after that, when prourokinase went away, we used intraarterial TPA for years treating acute strokes. It doesn't work very well. It really, in my mind, managing the platelets is so much more important. You can take out the hard chunks of clot that aren't going to dissolve. You have to take those out physically, but then it's really about the platelet activation and controlling that, it seems to me, which the TPA really doesn't address. So I think it's an interesting area, and the micro emboli thing are interesting, but there is a fair bit of experience that really didn't go anywhere because it wasn't working that well.
But Dr. McDougall, do you think, obviously you were part of the initial trials in 1999 and all this experience, but do you think the efficacy was compromised because we were dealing at that time, you guys were dealing with M1 occlusions. Now the concept is different. In CHOICE and other trials that are coming up now, they're going to use it once the vessel is open, when maybe there is some distal clot.
Right.
And also for the divos and mivos, especially with the T and K being superior, at least in the posterior circulation data from Australia and some of the anterior circulation, I foresee mivos and divo trials using probably also some type of IV thrombolytics for the M3s or M2s compared with medical therapy. Do you think maybe if it's more distal might be more efficient, or you still believe the antiplatelet might be more important?
I think it's really interesting, like the concept of putting the TPA in after after the vessel is open and the micro thing, there's that I can't really speak to that. I think that's intriguing. I think that when you're dealing with the M2s and the M3s, you're already dealing with a clot that's a little bit different. It's usually ones that are breaking up and they're going down and they're more amenable to dissolving maybe. And so there may be a role for, and plus we're not as good at the mechanical thrombectomies out that far, at least I'm not. So I think there may be a role there, but I think TPA without paying attention to the platelets, it's just, to me, the other place we see that experience is there were some original, in coiling aneurysms, when we had thromboembolic complications, TPA just doesn't work as well as I know it's a completely different situation, but the ReoPro revolutionized, treating aneurysms and the thromboembolic complications, whereas TPA, people had tried it and it just wasn't that effective. So the platelets, for whenever you're inside the vessel, you've really got to pay attention to the platelets and manage that. Thanks again so much for coming. I really enjoyed your talk. Learned a lot.
Thanks so much.
Thank you so much. It's been a really privilege to present to you, and thank you for the Seattle Science Foundation, and glad to have this amazing talk this morning. Thank you for the opportunity.
Thank you so much.
You take care. Bye-bye now.